Okay, so hello everyone. Thank you for joining us today for our CareAdvantage PCP P4P webinar to discuss our 2020 program updates. Today's webinar is being recorded and will be made available to anyone not able to join live. And because we've got a mixed audience here today, we are going to ask everyone to hold questions for the discussion portion at the end of the presentation. So everyone's lines are muted until we end the recorded portion of the webinar. So to jump right in, the topics we will cover today include a bit of context setting, how we got to today and where we're going next, an update on the P4P program structure in 2020, as well as an overview of the updates to the performance measures and some next steps.
And that is a lot of great stuff to cover today, and we'll get into a fair amount of detail on this program. But before we do, whenever we talk about value-based payment as a health plan and with our providers, we really want to pause for a moment to reflect on some of the why we're here. So this image is one that folks on the phone may have seen before in some of our communication materials and webinars, but the true North Star for the work that we're doing around value-based payment is trying to make sure that these programs align to really achieve the triple aim of healthcare. It's health of a population, our per capita cost as a steward of public resources, and then the experience of care for our members. So let's try to keep those three in mind as we go through our discussion today, and you'll see these reflected in the goals of this program.
For those of you who have been part of our discussions on the program or participated in any of our prior webinars, you've seen these concepts before. We've used these principles over the last several years through the development of our value-based payment programs, and they've continued to stand the test of time so far. This is really somewhat of a filter for how we build and implement our payment models, and the model development goes through several layers. At the highest level, the model itself needs to include the four ingredients that you see here of flexibility, accountability, adequacy, and adjustment. And then we develop our implementation process and timeline to account for the HPSM implementation principles, several of which we'll touch on throughout the discussion today. And then as we review the specific metrics included in the models, we review for each of the elements under the green arrow that you see here.
As part of our program development process, we reviewed the literature on this topic, and one example we consulted was an article by Harvard Business Review titled, "Don't Let Metrics Undermine Your Business." And this article discussed how a company can lose sight of its strategy and instead focus strictly on the metrics that are meant to represent that strategy. That tendency to replace strategy with metrics is called surrogation, and it's easy to do because the intent behind metrics is usually to capture some intangible goal. One example of a way that this tendency can be addressed that is discussed in the article is the case of Intermountain Healthcare. And Intermountain formulated a strategy to reduce invasive, unnecessary, and costly interventions for low back pain. And in doing so, they set their target for the percentage of patients who waited 4 weeks before medical intervention at 80%. This recognized that high-quality, low-cost care for most patients meant waiting for lower back pain to resolve itself, but also recognized that for some patients, immediate treatment was in fact warranted. So this target reflected the imperfect nature of the metric and drew physicians' attention back to the underlying strategy. Despite the pitfalls of surrogation, metrics do still add value because they help to give strategy form. So they provide direction where strategy may be amorphous, and they remain crucial because they allow us to coordinate behaviors and actions.
And to pull from several additional resources in the literature, we consider the performance metrics as they relate to the 6 domains and 3 types displayed here. And as we discuss the measure updates, you'll notice that they all fit into one of these domains and types. And to touch on the ways that we try to safeguard against surrogation, particularly in a program like P4P, being that it is very metric-driven, for strategy number 1 that you see here, it is involving the people who will implement the strategy in its development. So through our development process for 2020, we've involved stakeholders both internal and external to HPSM from our provider community. We hosted a provider forum in November where we gathered input on alignment across quality priorities and also discussed challenges and benefits of the P4P program structure and measure set. And this is in addition to the valuable feedback that we received and have taken into account from our provider community as we've gone through our program development process. For strategy number 2, what we try to think about through the program is how we account for where there are likely to be exceptions to the metric specifications and not letting those get in the way of the strategy the metric are meant to support. And this will be reflected in the targets for the benchmarks themselves. An example is similar to the Intermountain discussion from the prior slides. And then for strategy number 3, you'll see when we discuss the measure set that we try to include a broad range of metrics across the 3 types and 6 domains discussed on the prior slide.
And so thinking a little bit about how we apply these principles here at HPSM, we did want to also share with this group how we apply these internally. So we really want to practice what we preach on this principle of how we set our metrics and our goals, and do try to apply all of those principles when we are setting our own goals for the organization and the specific metrics that we use to track this. I won't go into exclusive detail here on kind of what all of those goals and metrics are, but we really wanted to highlight on this slide both our 3 strategic pillars, so the priorities for the organization, and then call out a few of the specific goals we've set for HPSM that are directly tied to the work that we are doing on pay for performance. And so really those 3 pillars for us, the 3 priorities for the organization, are around access to high quality care and services, strong internal operations at HPSM, and then financial stability, again, keeping in mind that we are a steward of public resources. What you'll see here in these examples is that there are many goals within each of those 3 that directly tie to what we're doing through this program. Making sure that we are better meeting our members' needs and strengthening our partnership with you, our providers. Making sure that we are improving our operations, including things like the technology that we use to communicate with our providers and share information. And then finally, making sure that these programs are sustainable for the long term and that they really do tie dollars to quality and to the great care that's being provided to our community.
And to share a bit about how we've put our implementation principles into practice when it comes to thoughtful rollout as well as evaluation and updates along the way, this is a snapshot of what our CareAdvantage P4P development and implementation process has looked like over the last several years. We've tried to build into the process not changing too many things too quickly, although it may not always feel that way. And this likely does not include all activities targeted at this program development, and we are not going to go through all of this today, but we did want to do some reflection and share back what has taken place to get us to today. So here is a summary of the program structure coming out of all of the activity on the last slide. And these are the structural components of the program and how that is changing from phase 1, which we are in today, to phase 2 starting January 1st, 2020. And again, this evolution was designed with our thoughtful rollout and adjustment principles in mind. Several notable changes outlined here. We are discontinuing our fee-for-service P4P program offering starting January 1st, 2020. In order for providers to be eligible to participate in our incentive program, they must have at least 50 HPSM CareAdvantage members assigned to the organization as of January 1st, 2020, and eligibility for participation will last throughout the calendar year. There will be 11 metrics assigned for payment and 7 additional that we will report back to our providers for tracking purposes. And similar to our current Medi-Cal benchmark P4P program, we will require that at the time of payment calculation, for which we use the April reports following the measurement year, providers must have at least 30 patients who qualify in the denominator by measure for the measure to be counted toward the payment calculation.
Through our discussion today, we want to share back with you all how we think about measure prioritization. As we all know, we can only focus on so many things at any given time for them to really be meaningful and for us to make any real impacts. So we're going to walk you through the various layers of consideration that we take into account for identifying sources of metric prioritization, specifications, and then refining the final set of metrics based on those two things. So we want to share with you how the plan has looked at prioritization of metric improvement. And these are some of the criteria that we have considered. The first that we have listed here is compliance and regulatory needs. We also considered financial management priorities, for example, the CMS quality withhold. We considered external quality reporting, such as HEDIS, and then internal quality reporting and priorities. So these would be items that support HPSM programmatic initiatives. And then we also considered internal administrative priorities, for example, the capture of encounter data. And then finally looked at current network performance rates and any areas for potential improvement. And these represent some of the sources from which we've gathered measure specifications. So again, the CMS quality withhold. We gathered many measure specifications from HEDIS, as well as the CMS core measure set. And then finally, again, measures that represent plan administrative priorities. For example, encounter data submission, timely filing, and plan engagement.
Okay, so here are the measures that we have in place today through our fee-for-service P4P program applicable to our CareAdvantage population. And here is the measure set for 2020. So anything bolded is new or updated. The box you see on the left-hand side in green, those are the payment metrics. So you'll see that there are 11 listed there. On the right in blue are the ones that we will be reporting back to our providers and tracking as they are still high priority. So these measures were run through the prioritization criteria that we just discussed and come from the various measure specification sources also just discussed. This measure set was finalized after taking into consideration feedback that we received from several of our network providers who participated in the measure set development process, as well as HPSM staff feedback and priorities. And we can come back to that slide during our discussion portion if needed. So before we wrap up, we wanted to give a quick reminder on some of the various reports that are and will be available to help our providers manage their panels and track progress toward the performance metrics. The two significant reports for real-time performance monitoring are the progress report and the member detail report. As those of you who have been closely involved with the program so far know, we have ongoing data capture and validation needs, and that will continue as an ongoing work in progress, and we welcome any and all feedback on how we can improve in this regard. The reports for 2020 will look similar to what you received today through e-reports for our Medi-Cal benchmark P4P program. For those of you not yet familiar with these reports, we're happy to provide some training for you and your staff on how to access and use these reports. And if anyone does not know how to access e-reports or would like to establish additional logins for your staff, please reach out to us after today's webinar. And in our discussion portion of the webinar, we welcome any feedback you have on what else would be helpful for you. And finally, just a bit on some next steps. So primary care contract amendments are out now, and the deadline requested was today. So if you have questions about this or aren't sure if you've received it, please do reach out to us. We will be continuing to follow up with our providers to make sure that we do get all of those amendments back, as they are effective for January 1st, 2020. And for some additional updates, we do expect to have our benchmarks by later this month, at which time we will update our program guidelines, get those posted online. We will update the reports that will come out in 2020 and get those out to you as soon as possible. And then we will be continuing with our testing and validation of the report specifications and data that gets shared. So with that, we're going to go ahead and end our recorded portion of today's webinar so that we can move into open discussion. I'll leave this slide up so that you have our contact information for follow-up after today on any questions that come up or on any of the items that we just discussed. So thank you all, and we'll go ahead and unmute everyone for our discussion.